Aquí podemos apreciar la imagen de tomografía computada de abdomen de la neoplasia de vesícula biliar con obstrucción duodenal.
Good morning. All right, we're going to start with a challenging case here. This is a patient who's been really suffering from gastric outlet obstruction. You can see the tumor as I went through the second portion. It's invading into the second duodenum. I was able to easily pass it actually with this double channel endoscope, gastroscope. Has a diameter of almost 15 millimeters, the double channel. So you can actually already assume if you put a duodenal stent, it's probably not going to help the patient that much. I think the issue for this patient may have way more to do with also the gastroparesis that these patients develop. So I think doing a gastroenterostomy is reasonable. You know, she has obviously some obstruction, it's contributing, but the hope is that we can give her a better quality of life by creating an EUS-guided gastroenterostomy. Now, the most important is to understand the small bowel anatomy before you begin. So I have passed the gastroscope as far in as I can get, and I think I'm somewhere, if you look on the endoscopic image, I'm somewhere between D3 and D4, almost at the ligament of Treitz. So if we step on the fluoral, and I want you to show the fluoral image, please. Do you see fluoral? So you see my scope, and my scope is going into, I've gone into the D3, and I'm looking at the ligament of Treitz or down towards D4. And now Miguel is going to advance the guide wire so that I can pass the ligament of Treitz. You can see the ligament of Treitz very nicely. And additionally, we also know there's no further obstruction downstream, because if you don't have a critical obstruction when you're going in, you have to consider the possibility there may be obstruction further down because she has metastatic disease, lymphadenopathy, a big mass. There could be compression of the small intestine further downstream. So that's what we're also looking for. Okay, so now let's pass the guide wire. And I'm going to use this endoscopic vision and fluoral. See if we can get that guide wire to go down into the ligament of Treitz. It's going sort of flipping back on itself. I'm going to try to push my scope in a little bit more. So we'll try to get it, if it can, this can be a little bit challenging. Getting that wire sort of hitting up against the ligament of Treitz. That's the ligament of Treitz right there. And if we can get it to flip over, that would be ideal. There we go. Almost. I think it's almost. All right, well, let's not waste too much time. Let's just leave it there. It's going to be fine. Okay. Let it coil. What's really important, and we don't need to keep our foot on the fluoral pedal the entire time. I'm going to leave the guide wire in place, make sure the guide wire doesn't come back, and I'm going to exchange the delivery catheter that I used here for the oral enteric catheter. Now, it's a nasobiliary catheter, but I call it an oral enteric catheter because that's how we're using it. We're not putting it in the bile duct, and we're not going through the nose, so it's not really a nasobiliary catheter. In this case, it's oral enteric. All right, so now I'm going to do the exchange. So Miguel is watching the wire.
Sure.
And we're not going to use fluoral. Just watch the wire, and we do an exchange. So advance, please, as I pull back. See, there's the jag wire, right?
Okay.
Okay, you just watch that wire. Make sure that the stripes don't move back or don't move forward. There's no need to use fluoral now. There's no additional information you're getting. As soon as I'm out, and I'm out now, I am going to now lock the position of my guide wire. And I'm holding it with my little pinky finger here. And now Miguel is inserting the oral enteric catheter, the OEC, over the guide wire. And we're going to advance that now under vision into the distal duodenum / proximal jejunum. And this is fine because we're going to be creating our anastomosis at the ligament of Treitz. We're not really doing a gastrojejunostomy. It's really more of a gastroduodenostomy, I think. But that's why I think the term gastroenterostomy is the best in terms of being anatomically correct. All right, so now he's going to pull on the wire as I advance the catheter forward. By the way, this is a 7 French, and I strongly recommend that you always use an 8.5 French. But they don't have an 8.5 French today, so we have to use the 7. But you should use an 8.5 because you really need to flood the small bowel with fluid, with your water pump. And the 7 does not really allow you to do that. Now you see the 7 French OEC, and I'm pushing it forward. And this is where now you can step on the floral and see, and you let this coil here, okay? So Miguel is pulling the wire back so that the pigtail releases, all right? So now this part is the most important, that you do not lose the position of the tip of your OEC. I'm going to be pulling out the scope. This is the double channel gastroscope as I advance the OEC forward, all right? And we don't need fluoral for this. You can just look on endoscopy and watch as I'm coming backwards. All we want to make sure of, it's a 1-to-1, is, and we don't have to worry even about the guide wire because we already put it back to deploy. Now here, as you pull out, suck out gas, suck out the gas, and make sure that this does not coil in your stomach. That's really important that this stays straight. All right, so I'm coming out. He's always using floral, but Miguel, let me control the floral. You're not allowed to touch the floral. You love floral, but I hate floral. So I don't need floral at all. I see all my information is endoscopic right now. Okay, so now I'm coming out. Now you grab the scope as soon as I'm out, please. Okay, now we're going to make sure that this oral enteric catheter does not pull out. So I have always one of my assistants who's just holding the oral enteric catheter at the patient's mouth. And the assistant's job is do not let that oral enteric catheter pull back under any circumstance. All right, now we're going to attach the oral enteric catheter to the pump. All right, so we're going to screw the pump in there. The wire is out, and we're going to use the adapter, and we're going to connect the pump to the oral enteric catheter. And then with my foot pedal, I can infuse saline, and we're going to mix it with some dye, methylene blue or indigo carmine, whatever you want, to give it a little bit of color so that when we create our gastroenterostomy, we have immediate confirmation that we have accessed the small bowel, the target. Okay, now I'm going to go alongside the OEC, the oral enteric catheter, with my therapeutic echoendoscope and to perform my GE. So now if someone can just pass me the echoendoscope. Sergio here, he's busy at work. He's going to switch out the scopes. And when I go in alongside, what you want to be very careful is that you don't push down too far. The gastroenterostomy is going to be created between the proximal body, the posterior wall, and the ligament of Treitz. That's basically, the ligament of Treitz always comes, there's actually a suspensory ligament that is between the stomach and the ligament of Treitz. So there's an actual suspensory ligament there that holds the two together. So it's a natural area of approximation of the small intestine with the gastric wall. So we want to take advantage of that. So we're going to be creating our gastroenterostomy at the ligament of Treitz. That's our target. And what we don't want is that the oral enteric catheter starts to get all coiled up and gets pulled back. So once it gets pulled back, we have to start all over again. And so we don't want to do that. So we want to make sure that we don't do anything that will cause the OEC, oral enteric catheter, to fall back. All right, so now this is the therapeutic Echoendoscope, large channel for the axial stent. Our plan is to place a 20 if we can, because that has been shown to provide the best palliation for outlet obstruction. I'm going to go alongside now, and on the endoscopic view, you'll see the OEC, there it is, right? It's blue. And I'm just going to go right alongside it. And I'm just sliding down. And this is the part now, as soon as I'm in the stomach, you see it's still straight, so that's good. And make sure you don't inflate too much, because really what I'm going to do now is we're going to switch. This is where I'll take over control of the floral. I want to bring on fluoroscopy the tip of the echoendoscope as close to that pigtail as possible. So I want to get the two as close together as I can before I do anything. I don't need to inject or put anything in yet. All right, so now let's see on the floral where we are. Okay, so let's move our, and look at this. I mean, talk about a good target. If you bring the x-ray just a little bit higher to the right, this is a beautiful view of the anatomy. You can see so nicely the nasal, the oral enteric catheter, right? It's going along the greater curvature here, antrum, into the bulb, into the second portion. This is where the obstruction is, we think, right? And then down here is the transition to the third portion, fourth portion, ligament of Treitz. That's where the natural suspension is, where the connection is. All right. Is the sound okay?
Yes.
Do I need to do anything? Okay.
Yes.
So this looks like a great position right now. So now's the part where I can switch to the EUS. All right. So now let's get the EUS image up. So up till now, it's just been endoscopic and fluoroscopic. Good. So I'm in right where I want to be. And so this is where we can get our pump ready. Everything's ready. Pump is here. And I need the EUS image, please, large on my screen in front of me. And you can have the endoscopic image small if you like. But really now you need to focus on the ultrasound. All right, so now an ultrasound. You can see here the confluence. There's the pancreas body. That's possibly a dilated PD there. I'm not going to spend any time with that. The kidney, so I need to move to the other direction. And now let's start to fill. So, Miguel, you can do that. Yeah, just start to fill, because I'm going to be looking for the small bowel that starts to fill it now. So we need to fill it really well, or I can do it. Let me do it.
Okay.
So here you see that right there in front of me? It's filling. You see all the bubbles? That's our target right there. Now, you need to be so careful, because I think we can get it ready to go. Let me have the
tips and tricks
okay
to avoid misdeployment.
Okay, firstly, you need to, it's just that I've got a good spot here. Let's go ahead and get the Buscopan ready, please, or glucagon. I like to give the first half now. The second half is going to be when I go inside. The most important is the dimensions, all right? So as we're filling this, we want to freeze for a moment and just kind of look at our runway. I call it the runway. And how do I measure this? Calipers, okay, here. The runway is here, and set, and we go down here. So this is 5 centimeters. That's really good runway there, right? Remember I said 38 millimeters is the runway for a 20 millimeter lens.
So
Okay.
23.5 is okay for the distance to place the exosystem for you?
Yeah, if you've got like 38 or so.
Okay.
Now you're going to see lots of loops of bowels here. There's another loop here. So we're going to have lots of loops to choose from.
This is better, this loop, right?
Maybe better, maybe better. But the one thing you must be really careful is that you do not go through a loop on top of another loop.
Exactly.
All right, so you have to make sure. So this may not be as good because it's not filling as well. So it's more downstream. And the one I love is the one where I see it filling. And then if you actually see the pigtail in there, that's even the best.
Do you see a little bit of ascites?
There's
Well,
a little bit of ascites, and that's a good point that
any
you're
problem
making.
with that?
Well, if there's significant ascites, you absolutely have to aspirate it out.
Okay.
But this looks like this might be a really good spot right here.
No escucho la pregunta, si quieren preguntar.
All right, so let's get the axials ready to go, please.
Okay.
So if I can have the 20, yeah.
Yeah, okay.
Esta pregunta.
Hola, Ángel, buen día.
Write it down.
Una pregunta, cuando hay obstrucción
Sí.
de salida del gástrica, cuando no es posible pasar una guía, que es otra indicación para la
And you already gave the
¿cuáles
Buscopan.
son las recomendaciones para identificar cuando la obstrucción es completa?
Buscopan.
There is a question for the others, Ken. If you have total obstruction in a patient, what do you do? Total obstruction. How do you proceed in that
And you
case?
said you don't do this.
Exactly.
That's the answer.
Any option in that situation? With total obstruction. It's the question in the audience. Okay. ¿Escucharon la respuesta?
Sí. ¿Se usa algún antiespasmódico para tener
Acaba de pedir buscapina ahorita. Buscapina o glucagon. Nosotros tenemos obviamente glucagon en México, ¿no?
I think that's actually the catheter that you see inside there. So you see something apogenic here.
Yeah.
I think that might be the catheter itself.
Este es el catéter dentro del asa de intestino delgado.
See the water going in?
Está el agua burbujeando dentro del asa. Ahora él está escogiendo la mejor asa para intentar tener una buena trayectoria de posición y profundidad. We are connected.
Need you to give the other Buscopan now, please.
Más buscapina, por favor.
So was it 0.5 you gave? All right, so you see the tip there. And
Entonces aquí ven el asa de yeyuno, aquí estamos en la luz gástrica y aquí está la punta de la prótesis de posición luminal, el sistema de liberación, y él está seleccionando el mejor lugar para hacer la punción.
and Miguel, I'm going to have you just hold the scope here.
Sure.
So really, because it's constantly
Esta solución instilada en el ayuno.
Agua pura.
we're just going to go for this.
Agarra
now.
fuerte.
So I'm stepping on the pedal the whole time, just filling it up as I go in. And slow, smooth, and steady. Second, it's not ideal yet. I want it really nicely in the trajectory.
Sergis holding the scope again.
And you may have to just don't get impatient, right? You can always look for a different spot. You really want to make sure, like you'll see something like this, and you go, "Oh my God, maybe this is better."
Right.
Yes, but you may have a loop of bowel, and then you can see there's some ascites there on the left, up here, and so even though this looks like it might be better, it may not be. Well, this looks pretty good.
Ya. Esta asa es mejor en eje longitudinal,
like
como lo ven
better. Let's
ustedes.
go in and do this one then. Okay, you saw the bubbles, right? Okay, I'm inside. You can see I'm pushing forward. As soon as the bubbles, you take off the cable. Okay, good. I'm pushing in as far as I can. And now I'm going to lock. I'm going to release the safety so that I can deploy the distal flange very slowly, very slowly, very slowly. Let's watch it open up. There it is. It's coming. Now it's fully open. Just give it some time. Make sure it's fully open. All right, now we can snug up. I'm just going to pull up like this, pulling up like that, and wait till it just deforms a little bit and you see a little bit of asymmetry. Okay? So it looks perfect right now. Now I'm going to lock again. So the black is locked so I can deploy the proximal flange in the working channel. And I keep my eye on the ultrasound to make sure that distal flange doesn't move. It didn't move at all. Now I'm going to switch to the endoscopic view. We have our gas on. I've unlocked the black. I'm going to turn my body slightly to the right. Look at Miguel here as I give gas, and I'm just going to slowly push forward until I start to see the lambs there. There it is on the right side. There it is, right? I'm going to push it all the way out like this. It is open. And I'm going to pull away slowly. Now, here's the fluid. Did you mix it with methylene blue?
No.
Oh,
Must
okay.
without.
You had me scared there because I was thinking, where's the methylene blue? Because I did ask to mix with the methylene blue, but it wasn't done. Now, you can just sit here and look and make sure that when you remove, this is the inner catheter that is connected to the nose cones. You see the micro wires there? Those are those wires. This is the genius of the engineers at Lumina, the company that I founded when we developed Axios. And this was the genius of the engineers so that we have we use this like a scalpel. It has almost only cutting effect and no coagulation effect. All right, so now we pull this out, and now we can see if we can look through. Now, my personal bias is if the patient is not really suffering, I don't want to go dilating this very aggressively because you may get bleeding. There's a small risk that it could migrate out. I just want the confirmation that I'm in the small bowel. So if you can see small bowel back there like this, and I'll start to give some gas so that we can look, and I'm sucking out all of that fluid that I infused into the small intestine when I did the procedure.
So most of the times you don't delay the...
You don't dilate it because it's going to dilate on its own. And I think that if you let it dilate on its own, it's going to be more stable. You know, I'm not putting a double pigtail through here to anchor it or anything.
Okay.
So I just want that one view, if I can get that one view through here, that shows
you can see
the small intestine. Yeah, I'm pretty sure that's it there. But if you can see the valvulae conniventes, I think they say in Latin.
Now you have more light.
Okay. One thing's for sure, this is not the peritoneum, okay?
How do you proceed with the diet for the patient?
Oh, the diet? Yeah, I would keep on liquids today. You know what? But actually, for this patient, you really don't need to worry because she's not completely obstructed. You know, I don't know. I think she can advance as tolerated, to be honest. Yeah.
But in patient with more obstruction in the duodenum,
You have to be more careful.
exactly.
Because of aspiration rate.
Liquid.
Yeah, I start with liquid and then I advance.
Any hours?
And I keep the patient for one day on liquid, and then I move to a pureed.
Okay.
And so pureed basically means it's kind of thick liquid, right? So, and then I advance from pureed to mechanical soft.
Okay.
And then I say it must be low residue. So
Exactly.
the things that clog are like salads. Salads do that. And then if they eat meat, they can have meat.
What about the vegetable?
Yes, but it has to be steamed or well cooked so it falls apart. It needs to be low fiber. So normally I'm an advocate of high fiber. In fact, I think that's the only diet that needs to be recommended is high fiber. But if there you see the small bowel, you see it? You see the villi? Yes? Or no?
Yeah, it's well.
Okay, you don't need more for...
Hot question.
Okay.
What about EUS-guided comparing to surgical GJ?
Well, obviously the surgical is way more invasive.
Exactly.
So I think if you can do this, you know, it's no different than all of the other procedures that of endoscopic that have really replaced the surgical alternatives.
Okay.
So in to the degree that this is palliative, if we can palliate this patient and give this patient a good quality of life and ability to eat, look at this. It's on the posterior wall of the proximal stomach. This is the perfect placement. It looks great. And by the way, we can take out the nasal enteric. Now we don't need that anymore. So pull it out. But this is a beautiful result. And then, so now the food has two routes. It can go this way through the gastroenterostomy, and it's going to actually preferentially go through here because the food will, you know, this is where the food collects first, and it's going to go this way. But then food can also go this way. And this is one of the reasons why everyone talks about duodenal stent or GE. Which one? I say, do both.
It's possible.
If you can.
Yeah.
Both, you know? Now, in this case, she doesn't need a duodenal stent because I can get through with the double channel scope without any problem, you see? Right? I'm just going right through it. But you know, if I couldn't go through, it's very friable, so I'm not going to push through, then I would place a duodenal stent. Why not? And gee, you want to give these patients really the best benefit in terms of quality of life that you can.
Okay. Thank you very much. We are going to change for another room.
Thank you.